Go ahead and get started with today's Flex Quality Networking meeting. And our focus topic today is on telehealth and kind of expanding the role of telehealth. We often get questions and about different processes. So we thought we would invite to share today two experts that we have here in the state with the Indiana Rural Health Association. We have Cameron Hilt and Dr. Cody Mullen. And Cameron has been the program director for the Crossroads Partnership for Telehealth and also an evaluator for the Upper Midwest Telehealth Resource Center and the Community Paramedicine Project. And then Dr. Cody Mullen is a senior advisor and works with IRHA and is also on faculty there at Purdue. Today's presentation will build upon Cam's presentation that will take place during the Critical Access Hospital convening meeting on April the 28th. If you haven't registered for the event, I provided the registration and the reminder for today and also in the calendar invitation. But we really look forward to hearing some of their best practices and things that they've learned over time across the past year in particular and during COVID. So Cam, I'll go ahead and turn it over to you and Cody.
Thank you so much for that introduction, Becky. So as Becky mentioned today, we're really going to be walking through some of the lessons we've learned implementing telebehavioral health programs in rural hospitals in Indiana. I'll go ahead and skip over since Becky gave a little bit of our introductions here. And just want to highlight, so we are programs that sit under our parent organization, which is the Indiana Rural Health Association, which is really focused on enhancing the health and well-being of populations in rural Indiana through leadership, education, advocacy, collaboration, and resource development. But we're going to be highlighting one of our programs today, which is the Crossroads Partnership for Telehealth. That I currently serve as the director, and Cody actually was the one who first started this program and served as the director, which we work with 9 rural hospital providers through 2 HRSA grant-funded programs. Really, with our grant-funded programs, what we're providing for those partner sites is an annual stipend, which they can use for whatever they need to really get their telehealth program started. So whether that be to help pay for staffing, pay for technology, pay for licenses, it's really be able just to offset some of the cost of starting their telehealth program and sustaining it throughout the course of the grant. We have focused specifically on telebehavioral health, teleneurology, and telestroke. This particular presentation, we're going to be focusing on our telebehavioral health grant, which actually ends at the end of this month in 2022. Our teleneurology, telestroke grant will continue through 2024. Additionally, with some of these services with Crossroads, we offer technical assistance and implementation support for those sites that we are working with for telehealth. And we also collect data for program evaluation and ultimately to be used to build the evidence base for telehealth. We also have another program with the Indiana Rural Health Association that's focused specifically on telehealth, which is the Upper Midwest Telehealth Resource Center. And so the telehealth, UMTRC is one telehealth resource center across the nation. So there's several other telehealth resource centers as well as a national telehealth resource center. But we specifically serve the states of Indiana, Ohio, Michigan, and Illinois. And really what we are meant to do is to serve as a one-stop shop for all things telehealth. So if any of you, since you're located in the state of Indiana, have any particular questions related to telehealth, you can reach out to myself or to our team, which is at the info@umtrc.org. We do provide free individual consultation, technical assistance. We will help facilitate connections with other programs, as well as hold a lot of events that are focused on the latest in reimbursement policy and legislative updates as it pertains to telehealth specifically. And so we also offer a lot of presentations and trainings, such as a monthly webinar series, a virtual view podcast, which is a bi-weekly podcast that's focused on telehealth specific topics, a virtual office hour, which is just something that we hold monthly, so anyone can hop on and ask any telehealth questions that they may have. So that's just a live Q&A portion that individuals can hop on for that. And then we have telehealth workshops and our telehealth training and demo center. So that's just a brief highlight of that. If you want more information specific to the UMTRC, you can visit us at our website, which is the umtrc.org. So real quick, I'm just going to go through our disclosures here. So these programs that are mentioned in this presentation are funded through the Health Resources and Services Administration. We have no conflicts of interest, and this does not express any of the interest or is not an endorsement by the Office for Advancement of Telehealth, for PERSA, or HHS. Sorry, so many acronyms in there. It's easy to get tongue twisted there. So with that, I will go ahead and hand it off to Cody to take over from here.
And Cam, before we move forward, there was a question in chat. Is the Upper Midwest Telehealth Resource Center a hospital contractor or available to Indiana hospitals through grants and state funding? So thought it'd be a good time to go ahead and clarify that.
So yeah, the Upper Midwest Telehealth Resource Center, we really are meant to be the federal resource for the general public. So really any hospital that wants to engage with us, the only time that there may be some sort of charge affiliated to engaging with the Upper Midwest Telehealth Resource Center is if there's an exhaustive training that's like a 1 to 2 day workshop, something that takes multiple hours for us to kind of put together. But when it comes to that individualized technical assistance, that is something anyone can reach out to us and ask those questions. So it doesn't require any funding to engage with us, but we are federally funded. But the Indiana Rural Health Association has had this funding for the Upper Midwest Telehealth Resource Center for well over a decade. So we've continually received this funding year after year, so that we have been able to build a lot of resources specific to telehealth during that time.
Thank you.
Well, good morning to everyone. It's great to see a lot of names on here that I've not seen for a while. So I hope everyone is having a great start to the year. And it's hard to believe that Q2 starts on Friday, or Q4, depending on how your fiscal year looks. But my name is Cody Mullen. I've been with IRJ for about 7 years and transitioned a little over a year ago to being with them only a day a week while I'm on faculty at Purdue University. I'm pleasured to be here today to talk about our Crossroads Partnership and where we have been and where we are. So this project was funded by the Health Resources and Services Administration, specifically their Federal Office of Rural Health Policy and the Office for the Advancement of Telehealth within that. So HRSA Forp Oat was our funder. And when we wrote this grant all the way back in the summer of 2018, we recognized that there were a lot of needs around behavioral health in the state. So we know that nearly 1/5, 19.5% of Indiana adults will experience a depressive disorder at some point in their life. And we have roughly 62.6% of our state is classified as a mental health professional shortage, as shown on the map on the left with the coloring. And if we think rural, we notice that the areas that are not a mental health professional shortage is Indianapolis, Terre Haute, our Lake County region, our Evansville region, and then our region there around Louisville area at the southern part of the state. So we recognize there's a huge need associated with this. Next slide, please. Cam and I are apart, so I apologize, but I'll be saying next a lot. So the goals of our project were to develop and maintain a telehealth network that will increase access to behavioral healthcare services in rural communities and conduct evaluation of the patient utilization. And then secondarily, it was to grow the evidence base for assessing the effectiveness of telebehavioral healthcare services for patients, providers, and payers. We're really excited when this grant opportunity came out for us to work on it, because not only did it ensure that we had services delivery, so we'll get into what all it allowed our partners to purchase, it also allowed us to collect robust data to support the delivery of healthcare and the delivery, to evaluate does telebehavioral healthcare really support? When we wrote this grant, we did not have COVID-19 anywhere on our radar, and we'll discuss throughout of how that's been a unique and interesting way as well to evaluate this. Next slide, please. So we wrote our goals into three main objectives. Our first objective is to recruit hospitals in geographically and culturally disparate rural counties across the state of Indiana. We then provide telehealth behavioral health equipment that will allow behavioral health providers to conduct virtual appointments with providers, and then to measure the effectiveness and utilization of these appointments by administering evidence-based instruments. And we're going to break all these down as we go through. So as you're thinking about, do we develop our own telebehavioral health network or system in our site? What were some of the considerations and lessons learned that we had? Next slide, please. So first thing, when I started IHA almost 10 years ago, which is hard to think, the saying was always shared with me: once you've met one rural community, you have met one rural community, and each community is unique. So as we go through our presentation, we'll be sharing different thought processes. But I want to pause and ask you to self-reflect on some of these questions as you're preparing to launch your own program or considering launching your own program. First off, what behavioral health services currently exist in your community or your target population? I recognize that several of our rural facilities support multiple counties or multiple regions around their region of the state. So that may vary depending on where you're at. Maybe there's a county to your north that has no CMHC, community mental health center, or services at all, where in your community where the hospital may be located, maybe there is a strong behavioral health component at the federally qualified health center or at the rural health clinic. So what currently exists? Secondarily, would your organization benefit from telebehavioral health services? And to answer this question, I strongly encourage you to reflect back on your most recent community needs assessment or other ways you've gathered the needs of the communities during or post the pandemic. Would the organization and your community benefit from offering these services, and how would they benefit? Quantify that. What would be success? What do we have to achieve to know we've reached where we want to be? Then lastly, what concerns or questions do you have regarding the implementation of a telebehavioral health services? The technology behind this is relatively simple. If anything, the pandemic has helped that. Everyone now knows how to do a Zoom call. My father, who I never thought could do FaceTime in his life, can now do a Zoom call on his own, right? So people are getting more accustomed to the technology, but there are still concerns or questions associated with that. Behavioral health is still a taboo subject for many parts of our society, right? If I walked in and said I'm a diabetic, no one would think any differently. But if I walked in and said I'm a schizophrenic, a few of us would have a pause to that, right? But the way we handle behavioral health is different. So what questions and concerns do you need to associate with that? Next slide. So I'm going to talk through our program setup. What are the technologies and other considerations you need to have associated with that? Next slide, please. So there's several different things that I want to include. What is the equipment or the location? What do we need and how do you deliver it? First and foremost, the first thing that really kind of shocked me when I started this program, and I'll be transparent, right, is I anticipated that our healthcare facilities, if they had strong internet, they would also have strong Wi-Fi. So we always ask questions about what is your internet capacity? What's your bandwidth, your upload, your download? Do you have the capacity for video conferencing? And most facilities said, yes, we did. But then once we got out into the ambulatory care settings that had that strong speed, their gateway or the router that they used to share that internet connection through Wi-Fi was very limiting to the point where it was non-existent, or patient rooms weren't part of the overall map that they outlined for that. So I always encourage you to think about what is the Wi-Fi there, right? Work with your IT or IS department to say, can this support a non-lag presentation, right? So patients can do that. Where are we going to paste this? Is this going to be in the ambulatory setting, or is this going to be in the emergency department? If you're in an ambulatory setting, do you have that efficient Wi-Fi? Do you have that welcoming environment? We'll show some examples of that. If you're in the emergency department, do you have a private room for that patient to have that encounter with the provider on the other side of the cart? Are they in a general area that has just curtains dividing the patient treatment centers? If so, they may not feel as comfortable sharing sensitive information about their behavioral health, knowing that neighbors or other members of the community may overhear the conversation. Secondarily, what technology are you going to have? What carts are you going to have? And things like that. We're going to get to that in our next slide, please. So what we used as part of our grant was a Jayco Cart. We got it from cdw.com. We are not tied or supported by these, but there's some pieces that we really liked about this cart. So the cart is there on the left. The iPad is securely attached. We used iOS iPad technology. It is securely mounted to the cart. It is locked in, so patients and staff cannot get the iPad off the cart. The cart raises, so there's a piston in it. So if you're standing or sitting, you can do that. The iPad flips around, and then within that tray, locked in with screws, is all the charging mechanisms. So there's a simple cord to plug in. You're not wondering where's that lightning support there. So once you have the equipment, though, the question is, do the personnel who are operating the equipment, are they trained on how to use the equipment? So what we recognized that technology can be scary for a lot of people. So every site that went live, we spent a day there, a whole day. So in the morning, we are very active working with patients, helping to do the technology. And then as the day went on, we phased out saying, okay, we're going to stand in the hall, call us in if you need us. And then by the end of the day, we were just in the break room doing our own work. Call us in if you need us, right? So what happens if the Zoom ends, right? What happens if the audio is disconnected, right? We've all experienced this during the pandemic, but when a patient, especially if they're in crisis in the ED, can't get that technology to work, it's even more strenuous, right? So they're training the clinical staff that are going to be supporting that, train the providers, right? How are they going to introduce it, right? If you're in a primary care setting and that patient needs a behavioral health consult during that, right? How are you going to communicate that this consult is going to be delivered via technology, right? Are the clerical staff and the billing staff aware of how this is doing? What technology do you need? Are you going to do technology a one-to-one? So every patient room has the technology, or for most of our sites, we have this on a cart and they're able to roll it room to room, right? And what is that movement? What is the cleaning protocol associated with that? Not something we really had to worry about until COVID-19. And then we really had to say, what is the cleaning protocol associated with that? And then where are you going to store it, right? Who's going to charge it each night? Who's going to be responsible for the updates each time and things like that? Next slide, please. So depending on where you are, so these are two examples of different carts utilized, right? So these are patients in their own room. So down on the lower left, you have a patient who's interacting with someone via Zoom. In this setting, they're in a traditional patient chair and they are left alone. There's no other provider in the room with them. In the other upper right corner picture, right, we can see that there is a provider on the EMR or computer, whatever, while that provider is also there. It's something to keep in mind when you're working with these patients, depending on the discussion that leads to it, there could be the identification of self-harm ideation. So if the patient expresses self-harm ideation, there needs to be explicit protocols in place of how will that provider who's on the telehealth get in touch with the provider who's in person, if it's in the clinical setting, to be able to go in and intervene, right? If the patient is escalating rapidly and they are preparing to do self-harm right then and there, who is going to be called? What is the order? Because the last thing you want is press 1 for the operator, press 4 for the nurse, right? And go through a call tree that doesn't allow for that rapid response. Next slide. Other areas have also identified that we want the setting to be very calming, right? So what we did, one of our partners, these are pictures from their site taken on an old iPhone, hence the blurriness of those, I apologize, right? But they set up their behavioral health provider rooms, not as patient treatment rooms, but specifically for telebehavioral health. So they have soft lighting, right? They don't have the harsh fluorescent lighting. They have different artwork on the wall. They have colored walls. They have soft furniture to sit on, right? Chairs, furnitures, coffee tables. They make it very casual. They also use TVs. So since the equipment's not moving room to room, they set up a TV with a webcam on it. So that person that they're interacting with, their face is more lifelike and not on a little iOS device. You also see in that other picture, they have aromatherapy, right? Soothing therapy that supports that. So depending on the goal, right? If you're dealing with crisis intervention or not, supporting that as well of what's going on there. Next slide, please. The next question really is, and I encourage you to work with your IT, your IS, your compliance department of what software do we utilize? This is HIPAA protected information that we are sharing. It's 42 CFR mental health information that's being shared. So you don't just want to go out and get the quickest and easiest thing. A lot of our sites utilize Zoom. Zoom now, I think that's like Kleenex, right? We're going to Zoom and then we say, what technology are we using, right? We just do it. There are HIPAA compliant Zooms, which require a business associate agreement being signed and different procedures put in place to support that, right? So just don't go buy the $99 Zoom. You need to get the HIPAA compliant Zoom. Support that. Some use WebEx, some use Teams. We had one site that preferred video, VIDYO, because it supported 4K interaction, right? So the image resolution, the Wi-Fi that they had supported that so they could have high resolution. Talk with your IT department. Maybe they already have a technology put in place. For example, Zoom, we bought 10 licenses. So we bought a package that was HIPAA compliant. They cost $100 a year per license. So for each device needed one license, right? And they were able to do that. So the investment in the software is minimal, but there is an investment. If you're doing those financials, make sure you include that. Next slide, please. Security, right? How are we going to secure this, both physically and in the software wise, right? So how are you going to lock the device? All of our devices use parental locks because it's iOS. So patients, when they get the device, they can do nothing to the device. They can't end the meeting. They can't get out of Zoom. They can't do anything with the device except interact with it. And then when the provider comes in or the care staff member comes in, they then put in a code where they can then end the meeting or go out. We also have removed all apps humanly possible, and the apps that we cannot remove, we've hidden as much as we can. So again, the device is used for one purpose. There's no Candy Crush on it. There's no Netflix on it. It is used specifically for that device. And then we have to make sure that there's rapid updates being done. So as new releases are coming out for both Zoom and the iOS or whatever device you're using for that. Also, we need to make sure we lock it down, right? These devices have value to them. There are stories you've heard talking to other providers of these devices being removed from the care setting, both by patients, but also by staff who would then go and sell them, right? So how do you lock those down? How do you track them, right? So Find My iPhone on iOS works for iPads. So all these are tied to Find My iPhone, right? So if they were to walk away and be activated, we would know roughly where it is. Again, an iPad's about $330. I did a lot of Black Friday shopping, so I got ours for about $200 on Black Friday when we were launching. I am frugal, it's federal dollars, so I wanted to stretch them as far as we can. So the investment for these things are not huge, right? But you also don't want them because once you need them and you depend on them. Next slide, please. The next area we looked at is that training that I've already mentioned, right? We do recognize there are generational differences associated with this. You know, you've seen all the memes on Facebook and social media of whose grandma's and grandpa's IT. It's the 3-year-old who's on the phone saying, click here, click here, click here, right? We recognize that, and we ensure that our staff, when we went out to do the training, recognize that just what someone assumes is common knowledge about using an iPad, for someone they may not have ever touched an iPad, right? So really, how do you unlock it, right? How do you charge it? How long does the battery last? We made sure we had a step-by-step with screenshot instruction manuals. So if we are not there or a new staff comes in, they can sit there in about 5 minutes, figure out what they need to do to be able to get that there as well. In our evaluation, we ensured that that equipment was being used. And then during the grant, we reached out every month and we had a process, right? So the first month, we went on site again to say, how's it going? Can we observe you doing this, right? What questions do you have? And as time went on, we gradually decreased that. And then COVID-19 ended that for us, right? Because we weren't allowed on site, and that changed as well. Next slide, please. So now you're like, okay, the technology makes sense. I understand how to do this. What's the billing mechanism associated with this? And I'm going to give a caveat I give to all these presentations. I'm not a certified coder. I'm not a biller. I'm an academic, which means I think I know more than I really do. So I'll put that disclaimer out there. And also, things are changing so rapidly with the pandemic. Things change rapidly in telehealth policy anyways. And then the pandemic literally was about 40 years of policy change happening in about 24 months. You've all lived this. You understand this. So the information I may provide right now may be a little out of date, and Cam could correct me as well, but also please use those UMTRC hours, right? Those are free time to call in and say, this is my situation. We have certified billers on the team that can help support and answer those questions. Next slide with that little caveat. So telemedicine, the standard model we use to think of this as is we had the patient and we had the specialist, in this case, the behavioral health provider, and they were separate, right? And we had to make that link via telemedicine. Where the patient was located, we call the originating site or the rural originating site. And where that specialist or that provider was located was called our distant site. There used to be a lot of laws associated what was an originating site and what was a distant site with the pandemic. I've sat in this very chair in my office and done telehealth, right? I don't have to go to a clinic anymore for being an originating site. And those laws are changing rapidly. And President Biden released new information last week. But to be honest, I haven't read the document yet. So all these are changing. But generally what happens is where the patient is, that rural originating site will bill a facility fee on Part B Medicare. This is a Medicare model, right? They'll bill that, which is usually $15 to $25, depending on the state, service times of like that. that support the overhead of the room, the rooming of the patient, and the technology. And then the specialist usually gets an 80% reimbursement of what they would normally charge if it was an in-person service provider. Next slide, please. So the beneficiary generally has to go to the originating site for the service. Usually that's either located in a county outside of a metropolitan statistical area or MSA, or is located in a HIPSA or a health professional shortage area. The site generally has to be a physician or practitioner's office, a hospital, a critical access hospital, a rural health clinic, a federally qualified health center, a skilled nursing facility, or a community mental health center. Please note that these restrictions for mental health related telehealth services have been lifted for the 2022 physician fee schedule, and the HIC code of that originating site that you bill will be a Q3014 code. Next slide, please. So who are the practitioners from that distance site, right? Who are the ones who are able to provide and bill for the care? So there are a lot of really great groups out there, including physicians, psychiatrists, psychologists, nurse practitioners, physician assistants, nurse psychotherapists, and clinical social workers who are qualified to provide these cares as well. Next slide.
Cody,
Yes.
this is Becky. Before we go on, there's a question in the chat that you might want to address right now. But can you go over how this applies in a federally qualified rural health center?
And Cody, I can take that one.
Thank you.
So Roger, federally qualified health centers, they do have a few things that are very unique to them. So there's actually guidance in the last physician fee schedule specific to that. I don't want to paraphrase. I'd rather just send you the document directly. So I'm happy to do that. If you want to provide your email in the chat box, I'd be happy to send that guidance to you.
Thank you.
It changed rapidly because we're about 3 months away from the fiscal year 23 proposed fee schedules coming out too. So we'll see what modifications that makes as well. So that distance site, so this is, remember where the provider is, they would submit a professional telehealth visit using their appropriate CPT or HCPCS code for the service that is provided. Their place of service would be O2 for telehealth that's provided outside the home. Now that we have what we call direct to consumer or in the home, we do a POS 10 for patients at home. And then if you're billing under COT optional payment modifier number 2, then you would need to add the GT modifier as well to all that. Again, CAM can provide all the resources to help understand that as well. Next slide. So these are examples of some of the HCPCS CPT codes that are associated with this around behavioral health care, right? So there are, and non-behavioral health care, but there are psychotherapy, there's pharmacological management, as well as behavioral health assessment and intervention codes associated with that. Next slide. So now I want to spend a few minutes talking about a different kind of model that has a different billing mechanism, and then we're going to drive into how we measure and screening tools, and then I believe I'll hand it back over to Cam. So the collaborative care model, or COCM, this is a model that has been tested and released by Medicare and Medicaid. Medicaid has not fully adopted it in our state, but other states have. If you support in other states, please check your state. This came out a lot when collaborative care, when chronic care management, or CCM, was being introduced. The collaborative care model, or COCM, is a 3 or 4-part model. This is led by the primary care provider. So this is the leader of the team. This could be an MDDO, but also be a nurse practitioner or physician assistant that leads the team. That primary care provider is partnered with the behavioral health care manager that is on their staff. They are trained in behavioral health, and they have a continuous relationship with the patient. And then there are patients who have behavioral health care needs that are supported by the provider and this behavioral health care manager. And then this whole team of the primary care provider and the behavioral health care manager, they work in tandem with a psychiatric consultant to help support the overall patient panel that is in this collaborative care model. So the psychiatric consultant, this does require to be an individual who can prescribe, so an MD, a DO, an NP, or a PA, who can prescribe medications and make medication recommendations. So the primary care provider, that PCP, can be working with a patient. The behavioral health care manager is engaging with that patient more frequently outside the clinic or within the clinic when the primary care provider may not be available. And then if there is a pharmacological need to prescribe to that patient, That primary care provider is now meeting regularly with the psychiatric consultant about the panel. They can present the case and then decide, is it best for the psychiatric consultant to be the one to prescribe that medication, or does it make sense for the primary care provider to be the one to prescribe that medication under the guidance of the psychiatric consultant? Next slide. So the requirements associated with this is the behavioral healthcare manager must have formal education or specialized training in behavioral healthcare. There must be a continuous relationship with the beneficiary, and there has to be a collaborative, integrated relationship amongst the care team between that prescribing psychiatric advisor, primary care provider, and that care coordinator. The care management services have to be provided face-to-face or remotely, but they do have to be able to see the beneficiary face-to-face if they identify this. This reimburses from Medicare, at least, as a PMPM, so per member per month reimbursement to provide the services. So it's outside of the CPT code. It allows for telehealth to be utilized without directly billing for those services. It allows the primary care provider to work at the top of their licensure. It allows that behavioral healthcare support staff, maybe an RN who has additional training in this to support it, and allows that psychiatric consultant to go on as well. That psychiatric consultant is then paid as a contractual individual from that primary care. So primary care provider gets the COC and PMPM payment, and then they have some sort of contractual payment that they pass on to the psychiatric consultant, either based on per members in the network or further out from there. Again, happy to provide. That can be a whole 1 hour presentation about the collaborative care model and how that works and the financials associated with it. So lastly, before I hand it over to Cam, I want to briefly talk about the screening tools that we use through our project. How do we measure these things? Again, as I did with the billing, I will give a caveat. I'm not a clinician. I'm a PhD in health policy and a background in statistics. So I understand the data structures of these, but I also don't necessarily fully understand the clinical implications of these. Next slide. So for the behavioral health screening and assessment, we utilize 2 main assessments. We utilize the GAD-7, which is a general anxiety disorder questionnaire. And then we also utilize the patient health questionnaire, or the PHQ-9. Next slide. So an example of the PHQ-9 is shown on the screen. This is a quick assessment. It's a 9-question assessment. Each assessment is asked from a 0 to 3 of not at all to nearly every day of how often the last 2 weeks have you been bothered by any of the following problems. You then sum up the score. So you have a score of 0 to 27, and then there's thresholds of what level of depression that is. We asked all of our patients as part of our grant to complete this every 30 days that they were seen. So we were able to see, did behavioral health care services, did it decrease their rate of depression? Did it increase or was it status quo, and where did it peak? A lot of sites had concerns about using the PHQ-9. I want to be totally transparent. I'm looking, so I'm drawing a blank. It's question number 9, right? Thoughts that you'd be better off dead or of hurting yourself in some way, right? So if you're asked that question, the patient does identify it, that they do have strong suicidal ideations. There was concerns. We don't have the staff to support the patient, right? Our protocol would be to have them report to the ED, where they lay for 8 to 14 hours, maybe longer, until we can find a transfer out of the community for that. We don't want to ask that question. Again, I encourage your clinical staff to have that discussion with administration of how do we support these individuals? How do we make sure we're collecting the most possible data to support them moving forward? Next slide, please. GAD-7 is very much similar, only PHQ-9 had 9 questions. GAD-7 has 7 questions. Again, scale of 0 to 3, so it's easy to ask the questions. Patients were common to them. Again, we asked them once a month to complete this, and then it's just a simple sum to reach a score. Next slide, please. So that simple sum then gives us severity and proposed treatments and actions. Again, we let our clinicians decide, are these things that they want to implement? Do they want to do this? So for example, PHQ-9 of like a 15 to 19, that's a moderate severity of depression, right? And proposed treatment may be immediate initiation of pharmacotherapy treatment, so medication, and then CBT, cognitive behavioral therapy, to help support that patient. Maybe mild is just watchful watching, and support that. But then there are other questions, right? We can't take numbers at face value. As much as a quantitative researcher, I want my number to be all the truth and nothing but the truth. There are other aspects. There are qualitative data points that we also, our clinicians, need to keep in mind, right? Have there been current symptoms been triggered by a psychosocial stressor? We noticed our PHQ-9 GAD-7 scores increased significantly during the pandemic, right? March, April, May 2020, everyone had some mild depression. Everyone had some mild anxiety with the unknown that it's occurring, right? What is the duration and current distribution? Has the patient received any treatment for it, right? What's going on there? Are there family histories, right? When screening for individuals of anxiety, right? What happens, right? Do we have those partnerships, right? When a score 10 or higher is reached, to refer out to pharmacotherapy or to refer out to cognitive behavioral therapy if our current care team on our staff can't support that. Next slide, please. The other area, right, this project really came out also of 2018. We're in what we thought was the height of the opioid pandemic and epidemic, and we saw some great improvements. And then the COVID-19 pandemic hit, and now we've lost all that, and our opioid and substance use disorder rates of fatalities have increased significantly above points we ever thought we would see. So we also have to recognize that this program could support not only individuals with depression or anxiety or other behavioral health needs. There is a substance use component to this, right? We recognize that among those with the substance use disorder, 1 in 3 will struggle with illicit drugs, 1 in 3 and 4 will struggle with alcohol use, and 1 in 9 will struggle with the combination of that, right? We recognize that roughly 20.1 million individuals, or 7.5% of the US society, have a substance use disorder at this time. We recognize that 18.3% of people the age of 18 or older have a mental illness at this time. And this data is dated, right? This is 2018 data, or 2016, pardon me. We'll have to see what happens as we follow the pandemic, right? And we see the co-occurrence of both substance use disorder with moderate mental illness. That's 8.2 million individuals in America, or 3.4%. This is not a minor subset of society. Next slide, please. So we put numbers among that, right? This is 18.4 million people struggling with illicit drugs, 28.3 million people struggling with alcohol use, right? These are growing and huge issues as well. Next slide. Around looking at substance use, right, there's a technique called SBIRT screen, brief intervention or referral to treatment, SBIRT, right? And there's a lot of sources out there, like CAM runs the TRC, UMTRC. There are SBIRT resources in the state that are federally funded to help come in and train your staff about what do we do, right? What are their pre-screening forms, and then what screenings do we do? So there are audit, which is an alcohol screening. There's the DAST, D-A-S-T, that's drug, right? There's all these different screening tools that get at different parts of substance use disorder. There are tools that get at all aspects of it, but those are very long. Patients don't like doing a 45, 50-minute screening tool and then not knowing if there's treatments in place as well. So again, keep that in mind. So I'll hand these back over to Cam to finish those out, and then he and I will both be available at the end for questions and answers.
Thank you, Cody. So really what we wanted to dive into next is, so Cody did a great job of kind of walking through, this was our program setup, this was the background, here is kind of how we structured this program and implemented it. I want to walk through what were some of the, what was the engagement in these programs? What did some of the data tell us as we were looking at it through the course of about this 3.5-year period? And so first, I want to kind of highlight the importance of measuring your programs.
I gave her my cell phone number.
I know
I figured
that
it'd be the easiest for her to get hold of me. If she can't call me back right now, that's fine.
It would probably be 5.
I think
we can hear someone.
Someone came off of mute.
Hey, are you muted?
Yes.
This one down here that Stacey's got is supposed to be for a consult. I think mine's
If
for
you
a
could
screen.
please mute your lines to cut down on the background noise, that would be helpful. Thank you.
So as you look to implement some of these telehealth programs, and I know that we are speaking to a lot of quality people today, so I feel like I'm preaching to the choir probably with this, but being able to validate what you're doing is ultimately having an impact on the populations that you're trying to serve. And so I just wanted to highlight this quote from the Institute of Healthcare Improvement, which says, measurement is a critical part of testing and implementing changes. Measures tell a team whether the changes they are making actually leads to improvement. Measurement for improvement should not be confused with measurement for research. And so especially when we're looking to implement telehealth programs, we're constantly always looking for ways of how is this improving quality of care that is being provided to the patients? How is it improving the quality of care that providers are able to provide themselves? And so when you're looking at how do you begin to evaluate a program like this? Some of the things to look at are looking at some of your outcome measures and your process measures. So process being, what were the things that's kind of with what Cody had walked through earlier of what are the things that need to happen in order for this program to be successful, for us to successfully implement it. And then ultimately looking at the outcome after those processes have been put in place. Within the context of these programs, especially if you had the ability to being able to look at what was happening before these changes were implemented and also track how those things change over time, only brings more validity to some of the results that you find with the data that you look at. And so before I dive into some of the aggregate data report from our program, I do want to note just a couple limitations with the data. So this is an aggregate report, so it's not separated into our individual sites. Because of that, some of our sites had earlier or later start dates. So it's not a true representation. Not all of our partners started at the exact same time. So the number of patients that we got from each partner varies a little bit between each. And so really the data that we have available currently is between September 2018 and December 2021. The data that we're reflecting in this doesn't include all of the encounters that happened during that time, as we're still receiving some of that data from partner sites currently, but it does capture a large portion of it. This is a humble plug for the Indiana Rural Health Association conference. Cody and I will be speaking at that conference in June. If you're really interested in seeing the full data set, we will have it by then. So if you're interested, feel free to check that out as well. And really, those were just some of the few limitations I wanted to talk about beforehand. So diving in first to the demographic summary of our population. So we saw about 1,268 unique patients that received telehealth or telebehavioral health services from our partner sites. We saw that predominantly those visits were for individuals who identified as female. That is similar to a lot of trends that we see with behavioral health care, with individuals who identify as male being maybe more resistant to receiving those telebehavioral health services, or perhaps facing some additional stigma attached to having a mental health condition that may be unique to that gender identification. And if there was a few that kind of fell into that other unknown, it was usually because they declined to answer that question. But that's a little bit of the, and the age was roughly around 38. So we did see, majority of the individuals who were engaged kind of in the middle age range. But once we go through some of the payer mix, you'll also see we had a large representation from private insurance and Medicaid, which also might explain some of that age as well. When it comes to ethnicity, we predominantly saw that individuals who were not Hispanic or Latino were the individuals that engaged. We did have a few Hispanic or Latinos that engaged in the program. Unknown would also fall into if they declined to answer or that information wasn't collected from that patient for any reason. So looking at some of the payer mix, for a lot of our sites, the two predominant payers were Medicaid and private insurance. Really, the reason for private insurance is two of our sites are actually located pretty close to large manufacturing sites that were able to offer that private insurance to the individuals that were engaged at that location. So we did see a bit of a higher private insurance utilization specific to those two sites, whereas Medicaid predominantly dominated majority of our sites, either as the top payer or the second top payer. And so we did see also, Medicare fell shortly after that, where we had about 17% of the population. We did have some dual Medicare, Medicaid that received services, and a few who were self-pay or uninsured who did receive those telebehavioral health services. When it comes to some of the primary diagnoses, really the these were the top 5 that we saw in our total population. The first being major depressive disorder, recurrent. So this is not acute depression. This means that this is a sustained or recurring depression. And so we saw over 322 patients who had that particular diagnosis code. And they had well over 1,608 telehealth encounters specific just to recurrent depression. Attention deficit hyperactivity disorder fell shortly behind that, with about 201 patients, 983 encounters, followed by bipolar, generalized anxiety disorder, and opioid-related disorders. And I did want to point out, in opioid-related disorders, you'll see that the number of patients with the diagnosis code is significantly lower than some of these other diagnoses, but the number of encounters per patient is significantly higher. So a lot of those patients who are coming in for opioid-related disorders, although the number of patients with that diagnosis code were low, their utilization of the telebehavioral health services was very high in reference to some of these other conditions that were being treated. And this graph below is just kind of showing a picture representation of the number of patients that were engaged in some of these services. Now, when we look at secondary diagnosis summary, the huge predominant secondary diagnosis was generalized anxiety disorder. So here shortly, when we walk through some of the comorbidity, this will kind of shed more light on this, but generalized anxiety disorder was the most common to be paired with some of those primary diagnoses that I talked through in the previous slide. So a large majority of the patient population did have this diagnosis. We did see, major depressive disorder, so severe stress and adjustment disorders, stress disorders falling as the third, followed by attention deficit hyperactivity disorder and bipolar disorder. So as we looked at some of the comorbidities of some of these behavioral health diagnoses, we saw, when you look at this table, the left side is identifying the primary diagnosis and is indicated with black text. The top, that's in the yellow, and the white text is the top secondary diagnoses. And so, as I said before, with a lot of those primary diagnoses, the generalized anxiety disorder was by far the biggest that had a comorbidity with one of these other conditions. And so that was something, that we wanted to be able to illustrate to our partner sites, just to be able to have that full picture of what are some of the comorbidities that exist, what are some of the most common, and if those do exist, is there any ways that the provider should be approaching their care differently in order to accommodate for some of those needs for their patients. When it came to the treatment service types, this is mostly from a billing perspective. So I'll kind of briefly go over this. And if you're not familiar with a lot of the billing for telebehavioral health, this will kind of preface some of the common codes that are used for billing for those services. So predominantly, we saw a lot of these services related to a typical outpatient visit. So either being in variations of 30 to 39 minutes, 20 to 29 minutes, or a 60-minute individual psychotherapy session that's performed by a licensed mental health provider. The 99215 and the 90792, they tend to be for more complex decision making. And so it does have a particular timestamp attached to that billing code, but most of it's associated to the decision making that is involved. And the 90792 has that psychiatric diagnosed interview examination, PDE, that is performed specific for that particular service. But those were our top 5 codes. Predominantly, the majority of those codes were for outpatient visits. For the purposes of this program, what we wanted to be able to illustrate for telebehavioral health services, and as Cody mentioned early on in the presentation, was such a large section of Indiana falling into mental health professional shortage areas. we wanted to be able to calculate and add some data to how far were some of these patients going to have to travel in order to receive telebehavioral health care in person. And so really what we saw, and this is looking at miles saved and time saved, or sorry, this is miles saved round trip. So the average between the majority of the population that was served for our program saved about 26 miles of travel round trip. And then when I'm talking about initial and next, so initial is based off of the place where they received that telebehavioral health visit. It's the next closest provider based off of their county of residence. Next would be maybe not the closest provider, but it would be the next closest. So it's basically the second closest telebehavioral health provider. So for that second or next site, we saw an average mile saves of about 48 miles, but we did look at some of our outlier patients and what some of their distances they would have had to travel to receive that care in person. And the longest distance that was going to have to be traveled was over 300 miles away for the initial and next. So for that patient, they lived in an area that was very, very far located from any telebehavioral health resources near them. And so this is just kind of equating some of those miles into travel time. And so we saw the typical average travel time that was saved for that initial location was about 36 minutes. For the next location for the 60 minutes. And then the longest being over 400 minutes that individual is going to have to travel to get to a good location to receive those telebehavioral health resources. The reason we highlight this is specific for telehealth, you know, especially for behavioral health. Typically, there's a lot, you're seeing that provider frequently, especially depending on what your diagnosis may be. And so when you have a mental health condition and you're having to travel for 36 minutes, 60 minutes consistently to go and receive that care, that's a huge barrier to really being able to receive that adequate care and making sure that patient can improve their quality of life and improve their ability to cope with their mental health condition as well. So we did see significant miles and time saved for those patients that were able to engage with those telebehavioral health services. And Cody walked through some of those screening tools. Really, one of the things we wanted to look at with those screening tools for telebehavioral health and behavioral health in general, it's difficult to quantify. So it's not diabetes, it's not hypertension, where you can look at A1C reduction or blood pressure reduction over time after engaging with these services. And so what we wanted to look at is by looking at some of these screening tools, and as Cody said, you know, it does help quantify. It doesn't tell a full story just by itself, but it can show us something as far as, you know, if an individual is engaging with a telebehavioral health provider and they're screened multiple times, are we seeing their average score reduce over time? And so for our population, we saw about 59% of patients were screened at least once. That was, you know, due to a variety of different concerns if they can connect it to their EHR effectively, you know, with staffing transition, you know, training that new staff to also screen those patients consistently. So that's maybe why that number is kind of erring closer to 60%. And we saw about 15% of the patient population who were screened 2 or more times. Now, in that 15% that were screened 2 or more times, we did see that there was an average PHQ-9 and a GAD-7 score reduction, which is positive to see that as these patients engaged with these telebehavioral health services, their screening scores for, and the reminder is PHQ-9 is depression, GAD-7 is anxiety, that some of those symptoms that they rated higher in their first visit, for subsequent visits, they were rating lower. And when we look at some of the average scores for some of those screening tools, really we saw that majority of those tools were falling into the moderate depression and moderate anxiety. However, we did see very, very high scores as well. You can see, you know, in this gauge here, the bottom right of the gauge, for the P29, we did have a patient who scored over 31 for that score being very, very, very severe depression, and saw a similar trend for anxiety as well. So the average score did fall within that moderate category, but we did see some very high scores as well.
Cam,
Yeah.
while you're talking about statistics, there is a question in the chat. Are the reductions statistically significant based on each test respectively?
So that's a great question, Roger. It's not something that we have currently evaluated yet. So since we're still in the middle of the program and still collecting data from some of our partners, that is an analysis that we plan on running once we have the complete data set. So definitely we will be looking at that in the future. We just don't have those specific results at the moment.
Cameron,
Yes.
this is Brad. I was the one who just asked the question. No,
Sure.
my thought was more for each test, is a reduction of 0.22 or 0.27 statistically significant in regards to the test to determine each test or the treatment's ability to affect the test scores? Not
Right.
whether or not the program's effective, but
Sure.
more is that test, what is a statistically significant change in each of those tests?
Mhm. Great point.
'Cause I would imagine since those are peer reviewed and been around for a long time, they probably have a statistically significant change that you would want to see in order to determine whether or not your treatments were successful.
Right. So I don't know that number off the top
Okay.
of my head. However, I would be happy to, I do have your email as well, so I would be happy to look at that and be able to share that information with you as well. And I don't know, Cody, if you have any ideas on that either. I don't have the exact representation for that, but I'll refer to Cody first.
Yeah, and I'll play I would be hesitant to make any recommendations without a clinician being on the team to help us understand clinically what they look at and not just a statistical p-value. To understand that, but I think that's a great point and definitely something we can look at and partner with some of our clinicians to say, does this make sense?
Mhm. Absolutely. Thank you for that question. So moving on now to some of our lessons learned. So really some of the main things that we learned through the course of this program is first, really being able to identify that telehealth champion. So this really increases the likelihood of a telehealth program being sustainable. It's great that the Indiana Rural Health Association wants to come in and to be able to help provide some of these telebehavioral health services. But if you don't have an advocate within that particular hospital or clinic or FQHC, whoever's implementing the service, you're going to be dead in the water very quickly. Or that program is not going to last past some of that grant funding because you don't have some of those internal advocates for the services. The next is, as Cody mentioned, technology is constantly changing. So be very ready to switch platforms, find out what works best for you. Being very agile and ready to adapt is something very important as you're implementing some of these telehealth programs. And then we did see that a lot of some of our partner sites were very positive in saying that the telebehavioral health services really helped reduce some of the rural Indiana patients' fears specific to stigma attached to mental illness. So patients really value the privacy when they receive this type of care in their communities versus having to go insight a person, someone seeing someone struck there and knowing that they're going to receive those mental health services. So we got a lot of positive feedback from patients that they enjoy being able to have that privacy. Lastly, when we're looking at some of the data collection, we understand that some of the data collection when it comes to rural facilities, depending on what EMR you may have, what type of staffing you have available to help you look at that data, you may not have some of the capacity to look at that. And so we understand that there are some challenges that already exist there. But also when it comes to collecting some of that good data, if you're utilizing screening tools, make sure to train some of those new providers who are hired, so that you make sure that they're consistently using those tools with each one of their patients. And so I know we're buttoned up to time, so I will stop there. Our emails are listed here. Please feel free to reach out to Cody and I for any follow-up questions or telehealth related questions for the Upper Midwest Telehealth Resource Center. So thank you so much for your time.
Thank you both. Really lots of great information shared. One quick question that I did receive is, there are many changes that do take place. What is the best resource to follow for the changes for telehealth?
So, there's a couple different resources. If you're talking from a policy standpoint, a good resource is going to be the Center for Connected Health Policy. It's CCHP. They follow a lot of legislation that's very specific to telehealth. Also, us at the Upper Midwest Telehealth Resource Center, every quarter, we put together a presentation called the State of the Region, which is focused specifically on any of the changes to telehealth reimbursement or telehealth policy. And so I am not a policy analyst. And so, I cover all the things that I keep tabs on. So I would say, attending some of the UMTRC events like that will be a benefit to you, but also supplementing that with engaging with the Center for Connected Health Policy. And there also is a law firm called Foley, which is Foley, and Laudner, Laudner, that focus on telehealth law specifically. So I think between those three resources, the UMTRC, Center for Connected Health Policy, and Foley and Laudner, you would be able to keep tabs on a lot of those different changes.
Great, thank you. Well, we are right at time. If you do have questions, again, Cam and Cody both shared their email. You're also welcome to email me questions and I'll connect with them. I have a few other questions that came in directly to me, but we'll address those in the follow-up email, which will include the presentation and the recording to today's session. So once you receive that, why certainly feel free to forward that to others in the organization that you believe would be helpful in hearing the information. So again, thanks Cam, thanks Cody, and appreciate everyone joining today. Hope you found the information helpful and encourage you to stay safe and well. Thank you. Bye-bye.
Thank you.